Okay, everyone, as we get ready and move on to the second of two sessions for this evening, I would like to welcome Dr. Lisa Guay Woodford to this evening's summit. Dr. Guay Woodford is the Richard L. Hudson Professor of Pediatrics at Children's National Hospital and the George Washington University School of Medicine and Health Sciences. She also serves as the Associate Vice President for Clinical and Translational Research out of that institute. After completing a residency and fellowship training at Boston Children's Hospital, Dr. Guay Woodford began her career at the University of Alabama at Birmingham. She has become an internationally recognized pediatric nephrologist with a research program focused on identifying clinical and genetic factors involved in the pathogenesis of inherited renal disorders, most notably autosomal recessive polycystic kidney disease. Her laboratory has identified the disease-causing genes in several experimental models of recessive PKD, and her group participated in the identification of the human ARPKD gene as part of an international consortium. In addition, her laboratory was the first to identify a candidate modifier gene for recessive polycystic kidney disease. For her contributions to the field, she was awarded the Lillian Jean Kaplan International Prize for Advancement in the Understanding of Polycystic Kidney Disease, given by the PKD Foundation United States and the International Society of Nephrology. Dr. Guay Woodford has established and directed national and international collaborative research groups, as well as assumed numerous elected leadership positions, including President of the Society for Pediatric Research, Counselor for the International Pediatric Nephrology Association, Chair of the NIH Cellular and Molecular Biology of the Kidney Study Section, Board of Trustee member for the Polycystic Kidney Disease Foundation in the United States, and board member for the Association of Clinical and Translational Science. She currently serves as a member of the NIDDK Advisory Council and somehow still manages to find time to join us this evening. So it's always an absolute highlight of my job in my life getting to speak with Dr. Lisa Guay Woodford. Welcome this evening.
Thank you, Jeff. Thanks for such a lovely introduction. My mother would have been so proud. It's a pleasure. It's always a pleasure for me to join my Canadian colleagues, and I truly love the PKD Foundation of Canada. So I'm very pleased to be here and happy to take questions after my presentation.
Wonderful. Well, we'll kick that off and we'll join for the Q&A shortly.
Terrific. I'd like to thank Jeff Robertson and the PKD Foundation of Canada for inviting me to participate in PKD Summit 2022. By way of disclosures, I serve as a consultant for Otsuka Pharmaceuticals and Natera Incorporated. I've organized the next 45 minutes or so in three parts. First, I'll give an overview of PKD, what goes wrong in this disease, and I do this primarily for level setting. Well, many of you know a lot about PKD. There are a number of people who are new to this annual summit, and I want to be sure we're all on the same page. So with this as the foundation, I want to then turn my attention to the autosomal dominant form of polycystic kidney disease. I'll talk about the key issues in children, current treatment strategies in children, and the promise of targeted therapies. And then revisit these same sort of main topic areas for the autosomal recessive form of polycystic kidney disease. So let's begin with talking about what is PKD. And to do that, we have to first think about what is the normal state. So this slide sort of summarizes at a high level the normal kidney. The kidneys are a pair of reddish-brown organs located on either side of the spine, just below the diaphragm, behind the liver and the stomach. They're bean-shaped, and in the average adult, they're about the size of your fist. The primary function of the kidneys, and those functions are affected by these functional units called nephrons that are made up of a filtering unit and then a long and very complex tubular structure. And these nephrons help the body remove waste, through the production of urine. They also help in terms of regulation of blood pressure, blood volume, and the chemical composition of the blood. And so this is the way that the kidneys really help maintain health. As I mentioned, removing waste and excess fluid, continuously regulating the body's fluid and chemical composition, removing some drugs and toxins from your body, and producing and releasing key hormones. Erythropoietin, which stimulates the bone marrow to make red blood cells, renin, which regulates blood pressure, and calcitriol, which is the active form of vitamin D that helps the intestine to absorb calcium from the diet and thereby maintain healthy bones, and in growing children, growing bones. Now, I want to spend a moment just talking specifically about the kidney in terms of handling salt and water. So as I mentioned, the functional unit of the kidney is this nephron structure, and at the level of the filter, on a daily basis, in the average adult, about 1,500 grams of salt are filtered at the glomerulus. And then the total urine output is about 6 grams of salt per day. And so you can see that, that an enormous amount of the salt that's filtered is reabsorbed. In fact, more than 99% of the filtered salt is reabsorbed, and that's to maintain your body's balance. In terms of water, a similar story. 200 quarts or 200 liters of water are filtered. 2 quarts, or essentially 2 liters, represent the average daily urine output for an adult. In terms of the liver is one of the largest and most complex organs in the body. It weighs about 1 pound and is made of a spongy mass of web-shaped lobes. And the liver really has a number of functions that are necessary for life, and those are listed on this slide. What I want to use this diagram on the lower left-hand side to point out is that the factory of the liver is this red spongy material. And that's really not typically affected in either form of PKD. What's affected is this structure that we call the portal triad. It's made up of the portal vein, a branch of the hepatic artery, and most importantly, the bile ducts. And the bile ducts are sort of organized so they follow the continuity of the portal vein, sort of in a vine-like fashion, in close approximation. And this is the structure that is abnormal in both forms of PKD, as I'll describe in a moment. I think it's also important with this quote primer to sort of briefly touch on definitions. And as I mentioned, I think it's important for us to use the genetic terms when we talk about polycystic kidney disease. And so when we think about an autosomal dominant trait, we have to think about the way genes are organized. Genes are organized in chromosomes. We have a copy of one chromosome, and therefore all the genes on that chromosome that we get from one parent, and a second chromosome with all the copies of the same genes from the other parent. In this schema, the father has the abnormal copy of a PKD gene. And with a 50% random probability, in this case, he's transmitted that abnormal copy to his son. And so his son is affected with this one abnormal copy. The daughter got the normal copy from dad, the normal copy from mom, and she's unaffected. In contrast, in the recessive disorder, both the father and the mother are carrying an abnormal copy of the same gene, but because you need 2 abnormal copies for a recessive trait, they are unaffected, clinically unaffected. However, with, again, completely random probability, each pregnancy has a 25% chance of getting this abnormal copy from the dad, this abnormal copy for the mother, which is the case for this affected boy. He has 2 abnormal copies, and so he has the recessive form of polycystic kidney disease, whereas his unaffected sister can have just 1 abnormal copy, or perhaps she was lucky enough to get both normal copies from each of her parents. So what is PKD? Well, PKD is an abnormality of a number of compartments. We focus most on the nephron, But PKD also involves the vasculature, shown here in red. These are the arteries, as well as the space in between in terms of inflammation and even inflammation leading to scarring. So while we focus largely on this tubular structure, have to keep in mind that PKD also involves the vasculature and the tissue that's in between the vasculature and these nephrons. In the liver, as I mentioned, by and large, the factory of the liver, the 95% mass of the liver is not affected in PKD. The PKD defect primarily involves this structure called the portal triad. Now, we talked about the genetics, and I think that's important to understand the genetics because we really need to take a lifespan view of the polycystic kidney diseases. I think it is misleading to talk about the dominant form of PKD as the adult form of PKD. And the reason for that is, while true, it is true that most patients present with clinically significant disease in adolescence or early adulthood. That's what this diagram is intended to show, the age of presentation. There are a subset, a small subset of children who present with ADPKD in the first few days of life or even the first year of life. In fact, in a large pediatric nephrology program like the one that I'm part of, we may see as many children presenting with this early onset form of ADPKD as we do children presenting with the recessive form of PKD. Recessive form of PKD have the lion's share of patients present in the newborn period or in the first year of life. And then there's this long tail that extends well into adulthood, where patients can present in their 20s or their 30s. And I would imagine that it is even possible with patients with very mild disease that they may be coming to medical attention even later in life. So I think this is the appropriate construct, is to think about the PKDs as the autosomal dominant form or the autosomal recessive form. So let's turn our attention now to the autosomal dominant form of PKD and consider the key issues in children, current treatment strategies, and the promise of targeted therapies. ADPKD has a prevalence of about 1 in 800 to 1 in 1,000. In terms of the molecular genetics, there are primarily 2 genes, maybe 3 if you stretch it a bit, that are involved in this disorder. There are other genes as well that cause far less than 1% of the cases, so let's focus here. The lion's share of patients with ADPKD have defects in the gene called PKD1. A smaller but distinct subset have mutations in PKD2. And then there's a very small group of patients that have defects in a relatively newly identified gene, GANAB. In terms of the renal disease, as I mentioned, this can be an issue for both children and adults. What's interesting about ADPKD is that only 1 to 2% of the nephrons are affected with these soap bubble-like cysts. But these soap bubble-like cysts can truly act as sort of bad apples in the basket and cause all kinds of problems, not just for the nephrons, but as I mentioned, for the vasculature and importantly, for that component of the kidneys that is the tissue between the nephrons and the vasculature. As a result, these kidneys can be normal in size if they only have a few cysts, or very, very large in size. If we think about the manifestations of this disease beyond the kidney, this is primarily a clinically significant issue in adults, not in children. Adults can get biliary cysts that are clinically significant, pancreatic cysts, vascular aneurysms, much, much less common a problem in children, hernias, and even male infertility. And so as you sort of might surmise, ADPKD has age-related manifestations. This subset of children that come to medical attention in fetal life or in the first year of life can have very severe disease. And in fact, 25% of them can progress to end-stage kidney disease before they reach adulthood. This in this presentation, the disease is almost exclusively confined to the kidney. High blood pressure is a big problem for these children. In contrast, children who come to medical attention, not imaging attention, medical attention. So this is not the, oh, somebody thought it would be a good idea to look and see. These are children who come to medical attention because they're found to have blood or protein in their urine. They have high blood pressure. And for these children, there can be an asymmetry so that one kidney looks relatively normal and the other kidney can have significant cysts. Historically, that was a problem because there was an effort sometimes, 30, 40 years ago to remove the more cystic kidney. We now know that the other kidney will catch up, and that's exactly the wrong course of action. But again, for these children, the issue in terms of their clinically significant disease is by and large confined to the kidney. And so that's where we're going to focus our discussion in terms of childhood PKD. And that contrasts to adult onset ADPKD, which is truly a systemic disorder, where there's not only kidney manifestations, but they're clinically significant: biliary cysts, aneurysms, and hernias. Now, in terms of the management of kidney issues in childhood ADPKD, this is largely information that we have quote unquote borrowed from adults. And that's an issue because while these issues may be important in childhood, how they manifest, what they mean, and how we treat them really should be examined in children. And there, as I'll talk about in a minute, there is a large international collaboration to do exactly that. But for now, when we think about, high blood pressure in these children, we manage them with ACE inhibitors or angiotensin receptor blockers as the first-line therapy. Abdominal and flank pain can be acute. It can be chronic. When it's acute, it often has to do with bleeding into the cysts, infection or stones. When it's chronic, very often associated with just the cyst burden of the disease. So very large cystic kidneys, those patients, particularly adolescents, particularly girls, around the time of their periods, can have chronic pain that relates to the cyst burden. Cyst hemorrhage and gross hematuria can be an issue for a subset of children, managed conservatively. Kidney stones can be a problem, particularly if kidney stones run in the family. Cyst infection has its own sort of issues in terms of how we should manage it. End-stage kidney disease, as I mentioned, this is particularly an issue for children who have very early onset disease. And this can be managed with dialysis and transplantation, just like a variety of other kidney diseases in children. Renal cell cancer, which is a small but distinct risk in adults with ADPKD, is very, very, very uncommon in children with ADPKD. And monitoring cyst growth, because the cysts grow at a steady, inexorable pace. In adults, we know from a number of studies that have been done in the US and around the world that the total kidney volume increases exponentially, and the size of the kidney relative to the age can portend how likely it is for someone to have a certain rate of decline in kidney function. And I'm not going to get into that here. You'll hear about this in some of the sessions about adult PKD. And the simple reason I'm not going to get into it here is this has not been validated for children less than 15 years of age. So it's something that we're very interested in, but how to do this in children in a meaningful way that really is a prognostic marker of disease course is not something that we have the information to do accurately at this point. In terms of management recommendations, there was a really wonderful international consensus statement that was published in 2019, and it says, as its sort of 3 take-home messages, children with a positive family history should be monitored for high blood pressure and for protein in the urine. And it is silent about should they have imaging studies, and that really is the subject of discussion between the family, with the child, if the child is old enough, and the medical team about at what point do you do screening ultrasounds. There's no right or wrong answer here. Subject of a lot of discussion. I'd be happy to take questions at the end about this. ACE inhibitors, as I mentioned, first-line therapy for ADPKD children. And ADPKD children should be strongly encouraged to achieve low dietary salt intake as recommended for all children. So there's not really special dietary recommendations except to follow the guidance about what we should have as salt intake for all children. Now, in terms of PKD biology, this is a very sort of complicated slide, and it really is a wiring diagram. And what it's intended to represent is the different pathways that regulate functions in the cell. And we know, we have a good idea of what goes wrong in PKD in terms of this cellular pathways, this cellular wiring diagram. One thing that goes wrong, a signature of cystic epithelia, is an increase in cells of a substance called cyclic AMP. And the level of that substance is regulated by two different receptors. And they're shown here in the bottom of the cell. So this is urine facing and this is blood facing. And this, if you think about this as a baseball glove, and it's catching the ball of AVP, and something goes wrong in PKD where this baseball glove, this receptor is driving cyclic AMP, which is what we don't want. And so a very important therapeutic agent essentially stops this glove from catching this ball. It's a blocker of this receptor. It's called tolvaptan or Jynarque or Semska. In terms of other sort of features of this wiring diagram that have been studied in animals, and there have been some initial studies in human, but nowhere near as advanced as the tolvaptan Jynarque Semska studies. There is a pathway that is very involved in terms of sensing the energy level of the cell. It also seems to have gone awry in PKD, and we have agents like everolimus to block this pathway. There is a mislocalization of a different kind of baseball glove on the urine-facing side of the cell that is driving a pathway that leads to cell multiplication or proliferation. And there are agents that can block this pathway. Tesavitinib is one that has been studied, at least initially, in PKD. So we have a number of druggable targets. What does that mean for children with ADPKD? So again, going back to the international consensus statement, the V2 receptors, the tolvaptan, should not be offered routinely. They do have this agent does have side effects. It can be used off-label in selected children. And a case in point that I'll talk about in a minute is children with severe, very early onset disease. And it has proven in a very small number of those children to be an effective agent. There is no consensus on the use of statins, which many of you who have ADPKD in the audience thinking about, well, should my child be on a statin? We just don't have enough information to say that this is something that would benefit the child. So we're silent on whether or not it should be used. And mTOR inhibitors and other sorts of agents, those other agents that pick out other sort of windows of potential therapeutic benefit on that wiring diagram, they're not recommended, partly because the studies are not yet conclusive in adults, and obviously we want to be sure that we keep our children as safe as possible. Above all, do no harm, so it's not recommended. So this is the story about tolvaptan use in early ADPKD. There was a little girl born in the UK who had actually inherited PKD1 variants from each parent. She had the same sort of clinical presentation you would expect from a child with ARPKD, really huge kidneys, severe high blood pressure, low levels of salt in her bloodstream because she was just holding on to too much water. And her lungs just really didn't work very well because of her hypertension and her heart not working efficiently in the context of hypertension. She was treated with tolvaptan from essentially 1 month to 12 months of age, and things got remarkably better. And the accelerated growth of her kidney, which they were witnessing over the first few weeks of life, was substantially arrested. And so I think what this sort of case report demonstrates is that that tolvaptan even in a very young child, in a baby, that has very severe disease was tolerated, and in this situation actually was able to blunt the course of the disease, holding promise for its use again in maybe a bigger retinue of children with targeted indications. So you could ask yourself, well, so how do you do that? You do that in the context of clinical trials, and this is a summary of the clinical trials in children from around the world. Now, some of these are registries, some of these are drug trials, but you can see that unlike adults, there are not a lot of trials for ADPKD in children. And part of the reason for that is we need to have a research-ready cohort of children where we understand the course of their disease, what the issues are in terms of high blood pressure, in terms of kidney size, in terms of blood in the urine, and protein in the urine. And to do that, Dr. Jalila Micheli in Belgium has organized a number of centers in Europe. We've joined her collaboration from North America. There are investigators from South America, Africa, Asia, and Australia to develop a longitudinal international registry of pediatric ADPKD patients. You can see the sort of the criteria on the left-hand side of the slide. Suffice it to say, I think the key take-home message is it's an international effort that now has registered over 1,500 patients. So those issues about borrowing from adults, in the next few years, we should have data that are specific to children with ADPKD to guide how we approach their management. So let's turn now to ARPKD, the recessive form of PKD. This is much less common than the dominant form of PKD. The molecular genetics overwhelmingly involve defects in one gene, PKHD1. There are a small number of patients that have mutations in two other genes. Interestingly, CYS1 is the gene that's disrupted in the animal model that has been studied for almost 50 years. The animal model of PKD that has been studied for almost 50 years. And so the use of animal models, I think as genetics progresses, we're getting more and more of a sense of when they are useful. And in this case, it turns out that it is useful in terms of studying recessive PKD. The renal cystic disease is very different than what I showed you for ADPKD. It doesn't involve soap bubbles. Instead, it involves this dilatation of these collecting duct structures, but this dilatation can lead to very large kidneys. And unlike ADPKD, where there can be clinically significant biliary disease, or maybe not, in ARPKD, there is always a biliary abnormality, and in a large percentage of the patients, it becomes clinically significant. So this schema sort of shows you the disease in a sort of a different way. This is the, this is the normal nephron. This is the cyst formation with the dilatation, and these are the massively enlarged kidneys. In the liver, here is a representation of a portion of the portal vein, the lattice-like network of the bile ducts around it. Something in ARPKD goes terribly wrong so that the branching pattern of the portal vein is not normal, and the associated bile ducts are really chaotic. They somehow have a block that they don't go from these collar-like structures to form this beautiful lattice-like network. And as a result of this abnormality, they can set up inflammation and scarring between the portal vein and around this abnormal bile duct, a lesion that we recognize as congenital hepatic fibrosis. The reason that's important is here's a schema of the portal vein going into the liver. The bile ducts are around it that are abnormal and the scarring, and that puts pressure on this vein such that the pressure in the liver is higher than the pressure in the vein coming in to the liver. And that causes actually the blood to sort of back up and go in a different direction, and for those veins to become dilated, something that we recognize as varices. So in a nutshell, this is the pathology of the recessive form of polycystic kidney disease. We've used the electronic health record to estimate the incidence. I mean, how often does this happen? We estimate that it's about 1 in 26,500 live births. We worked with an international collaboration using genetic data. We came up with 1 in 20,000 live births. So I think this is a pretty good number. What's important is this analysis allowed us to truly get an estimate of the percentage of patients who die in the newborn period. You'll look on the internet, and it will say 50 or 60%. That's not the data that we have. It's about 21%, still very high, but not the majority of patients dying in the newborn period. And then in terms of the prevalence, so what does this mean? If it's 1 in 26,000 live births and about 20% of them die in the newborn period, it means that in the US, we have about 1,500 patients between the age of 0 and 30 who have ARPKD. So a large number of patients who potentially need medical management, but also who potentially can be involved in clinical trials to help advance our knowledge of this disorder. In terms of survival, this is somewhat old data, but it really hasn't changed substantially. If patients with ARPKD die, they die in the first few weeks of life. And our data suggests that they die within the first week of life. And then there's a long, long period, well into adulthood, before there's the next mortal event. In terms of clinical features, let's first think about newborns. Typically, these children are born a little early for reasons we don't fully understand. So between 34 and 36 weeks gestation, their major clinical issues are that they can have poor lung development. And as I mentioned, there's a risk of perinatal mortality. And their other major issue is the kidney: hyponatremia, decreased kidney function, very large kidneys, and hypertension. For children who come to medical attention a little older or progress out of the newborn period, their issues can be respiratory with poor lung development and chronic lung disease. Although, interestingly, chronic lung disease, despite the poor lung development, is really not a prominent feature for most children with ARPKD who survive the newborn period, even a stormy course in the newborn period, for reasons we don't really understand. It's sort of good news, but we don't really understand why. The kidney, electrolyte abnormalities, in addition to the really large kidneys, electrolyte abnormalities, hypertension, and then a variable course with declining kidney function. In older children, portal hypertension, as I mentioned, due to that scarring around the bile ducts and the portal vein, the dilatation of the veins outside the liver, causing varices that can bleed. And because the bile ducts are so abnormal within the liver, they are subject to infection. We call that cholangitis. Feeding issues can be a major issue. Most likely it's due to the massively enlarged kidney compromising the normal motility of the GI system. And there is now, this is work that's been largely done by Aram Hartung at the Children's Hospital of Philadelphia, that there can be both intracranial aneurysms and even extracranial aneurysms in children with genetically confirmed ARPKD. Only a handful of children, but an important thing to think about, because if you're a family with that particular issue, it's a major sort of issue. And again, happy to talk a little bit more about that in the question and answer period. Clinical management, the major issues for these kids: low blood sodium because of dilution. They're holding on to too much water. High blood pressure, which can be a major, major problem. For reasons we don't understand, these kids are at increased risk for urinary tract infection. Chronic kidney disease is a major issue for these kids, progressing very often or can progress during childhood to end-stage kidney disease. I mentioned growth issues. Chronic lung disease, interestingly, not really a clinically major complications, portal hypertension, and then I talked about survival. Targeted therapies, the same figure applies. And so you'd say, well, that's great. This is a terrible disease. So there'll be a lot of clinical trials trying to figure out a therapy for these children. And in point of fact, there are less clinical trials in ARPKD. And you ask why? Well, why would that be? It's a devastating disorder for most of these children. Why wouldn't there be even more clinical trials looking to identify targeted therapies that will blunt the disease course? And the reason for that is while the potential disease, the disease mechanisms are related between ADPKD and ARPKD, suggesting that ADPKD therapies may be effective in ARPKD, In ARPKD, disease onset, the cystic lesion developing in utero and children typically being born with massively enlarged kidneys by birth. Kidney volume is not an inexorable increase over the course of time. It can increase rapidly until 2 to 4 years of age. Then the growth can slow due to secondary scarring and loss of nephrons. And then the kidneys can actually, relatively speaking, appear to shrink. So we can't use total kidney volume straightforwardly in assessing disease progression. Kidney function is quite variable and not well correlated with disease severity. And until very recently, we didn't have predictive markers of disease progression. So what can we do about it? Again, research-ready cohorts. As I'll talk about in a minute, there are international databases. Continuing the work to understand what goes wrong in these cellular wiring diagrams, what's common as a common feature in PKD and what's specific to ARPKD. Trying to identify biomarkers, those markers that say one child is going to have a mild course, one child is going to have a severe course. They can be clinical markers, biochemical markers, genetic markers, or imaging markers. And then therapeutics, not only looking for novel agents, but looking for agents that have been developed for one indication, but applied to the defect in that wiring diagram. That's true for tolvaptan, and can be applied to this particular situation. So here's a summary of the databases. Max Lebo leads a really remarkable database in Germany that has registered a large number of patients from Germany and Turkey, and as well as from a number of other European countries. They actually have, I think, close to 700 or 800 patients at this point. We have a database in North America for US and Canadian patients, and continue to actively recruit. And then there is a registry for ARPKD patients in the UK. Now, from Dr. Lebo's registry, they have been able to start to look at predictors of declining kidney function. And here they focused on clinical predictors of a rapid decline in kidney function. This is a very complicated slide, so let me take you through it. For those children who are born with oligo or anhydramnios, either decreased or absent amniotic fluid, large kidneys, and evidence for renal cysts, those children had a almost 33% risk of needing to have dialysis by 12 months of age. Whereas children who had genetically confirmed ARPKD, but really didn't have a whole lot of perinatal or prenatal abnormalities, they had about a 1.5% risk of requiring dialysis by the first year of life. And so you can carry that on and look at 36 months of age. The risk goes up a little bit in the most severely affected children, but it doesn't really change a whole lot in the most mildly affected children. So again, now we can incorporate these features, oligoanhydramnios, enlarged kidneys, renal cysts, into our counseling of families, but also into the way that we think about clinical trials and looking to see agents that can blunt disease course. And so if we go back to thinking about ARPKD clinical trials, a number of these studies being done in the United States and in Europe, or a number of sites in the United States and in Europe, are involved in now tolvaptan studies. Again, tolvaptan developed as a targeted therapeutic for ADPKD, shared biology, looking to see will it be effective in 2 cohorts of children. Infants between 28 days or 1 month of age to less than 12 weeks or 3 months of age with ARPKD, looking specifically to see, can tolvaptan delay dialysis in these infants, using that clinical biomarker, saying that these are the features that would be associated with an increased risk of dialysis. Can tolvaptan decrease that risk? And then a broader study looking from 1 month of age all the way to 18 years of age. And here what we want to assess is what's the best tolerated and the safest dose, so that we can use this as the prelude to doing larger efficacy studies for children with ARPKD. So to summarize, PKD is a clinically significant disorder in children. While polycystic kidney diseases are clinically distinct, many disease manifestations are common. Current therapy focuses on supportive management, but clinical trials are actually now a reality. And a clinical trial design for targeted therapeutics has been in the past hampered by the lack of prognostic and predictive markers. And with these newer insights is now being advanced because we're beginning to get a handle on prognostic and predictive markers. And I think that the other important point is research-ready cohorts are changing the landscape. Cohorts of children who are well characterized, who are enrolled in a registry as the first step to being involved in research. That registry can then be tapped, looking for children to participate in these clinical trials. And that's hugely important for us to move our knowledge forward and to advance the care of these children. So I'd like to acknowledge my collaborators at the University of Alabama at Birmingham and Children's National. I was at UAB for 20 years before I moved to Children's National. My international collaborators are US ARPKD and ADPKD database collaborators. I'd be very happy to have Canadian collaborators as well, and our funding sources. Here's my contact information, my email address, and our websites. And let me pause here, and I hope that I've left a substantial amount of time for discussions, and I'd be happy to take your questions. Thank you very much.
Thank you, Dr. Guay Woodford. That was a fantastic presentation, and wonderful to see the progress is being made for children with ADPKD and ARPKD. I can remember not so long ago, there was a lot less happening, especially in the ARPKD realm. So we cannot understate the value of the registries. I think that is going to open so many doors and opportunities for the kids. And I think that's a marvelous initiative that you've been a part of. We have some questions here, if I can start throwing them at you. We get a lot of inquiries from folks that are concerned about the transfer of care from their pediatric nephs when they go into adult nephrology. The relationships they forge with folks like you and at Sick Kids here in Toronto is second to none. So you can appreciate the reservations about going into a different style of care. Can you speak to, I guess, how you assure those patients of yours and their families that the care will continue in a positive fashion and that it's, that it will continue?
So I think that's a terrific question, Jeff. You always ask such insightful questions. I guess I would start with there's a short-term answer and there's a longer-term aspiration. Let me start with the short-term answer. The short-term answer is that we need to prepare our patients for that transition. At least in the United States, when you transition from a pediatric healthcare system to an adult healthcare system, things change remarkably in terms of the way care is delivered, et cetera, et cetera. But one of the big things that changes for our patients is their parents are no longer allowed in the room as sort of as a given. And so I actually start preparing patients for this transition to an adult care system. I typically pick their junior year in high school. I start to talk to them about, well, down the road, you're going to leave the children's hospital. See how big you are. You can't even fit on the examining table anymore. And we begin the discussion. And the first part of the discussion is to determine when they want to transition. So unlike our colleagues in Europe, and I'm embarrassed to say, I don't actually know the typical way things are done in Canada, but unlike our colleagues in Europe that transition at a certain age, in the US, particularly children with rare diseases can stay with their pediatric providers, certainly through college and even into their mid-20s. And an awful lot of our patients, take that route. But that doesn't mean that we can't spend that time really informing them about the key points for consideration in terms of their management. Their issues are blood pressure. Their issues are kidney stones, for example, our ADPKD patients, et cetera, and that they understand not just what the issues are, but how we tie their issues to their management. And so, starting again in high school, when I go into the room, I ask the child, what medicines are you on? And, and we will make a joke of it because very often they either won't say, or they don't remember, or they really don't want ownership of it. And so trying to get them to be comfortable with what is their medical management. Another thing that I begin to talk about is the way that children's hospitals are set up to deal with what is a pretty rare event, and that's a sick child, where adult healthcare systems are set up to deal with adults where illness is much more common. And so adult systems really are tailored to those more common diseases. It's not uncommon to see an adult healthcare provider and have them spend 15 minutes with you. That is pretty much unheard of in a pediatric context. And so the descriptor I want to use is a gamification strategy. So how are you able to use that 15 minutes so that you understand what's going on and you can convey to the healthcare provider what's going on. So it's a process that I begin early, knowing full well that a lot of these kids will be with me for a number of years so that we can slowly get to the point, or at least aspire to get to the point where they have an understanding of what are the major issues in their disease and what is their medical management and what are the issues down the road. So for example, in my ADPKD kids who come from families where there is a family history of not just ADPKD, but ADPKD associated with strokes, is, we'll do their initial screening studies, their brain imaging studies before we transition them, but that during the course of their young adulthood should be done again, with a certain periodicity, and it depends on the child. So we talk about that for each child. But I think respecting the child who is about to transition into adulthood, and empowering them, those are my catchwords today. What I'd like to see down the road is that we begin to think about the fact that we are not just transitioning a child from a pediatric healthcare system to an adult healthcare system. We are transitioning a patient with a rare disorder to a system that is designed to care for common disorders. And so I think that the future may well be, as well-intentioned as we are and as much as we prepare our patients, it's not uncommon for them to come back to us saying, I hate it. I don't want to go there anymore, right? You've heard that. And it's because the systems are so different. So one possibility, and I think COVID really pointed this out, we had patients who were in their 20s and 30s with rare diseases who got COVID and went to adult emergency rooms. Of course they did. They were very sick with the intercurrent infectious disease. And the adult healthcare facilities would call up their pediatric partners and say, we don't do this sort of very rare disease. We're sending them back. So here's someone who has a rare underlying disorder that's rare. So the adult system isn't comfortable with this, who is wanting to be sent back to a pediatric facility that isn't prepared to care for them as a really sick adult. And I think that what that has prompted is an idea that a number of us have, and I know my colleagues in Canada are also thinking about this, is to be thinking about transition clinics, where an adult provider, not just trainees, but an adult provider who's interested, is, for example, a nephrologist who might be interested in these rare disorders. And I've started this with some of my colleagues at GW, comes and sees patients in this same clinic. It works really well obviously if the programs are close. And this has worked great in Toronto, for example, comes and sees those patients, that the notes from those clinics are mirrored in both the pediatric and the adult care system. So if that patient develops an issue that is beyond their underlying disorder, they go to an adult care facility because that's the appropriate place. But the poor folks in the ED are not sitting there going, what is this? They have records and they have a physician to call. So this would be a multi-stage process. This would also obviously involve a partnership among nursing staffs so that nursing staffs were comfortable. But I think we need to think about a different way of doing business around children who have rare disorders, moving from a healthcare system designed to take care of kids with rare diseases. Because after all, aside from trauma and infectious disease, most illnesses in children are rare, right? And then transitioning to an adult care system that's designed to handle high volumes of common disorders. I think we're going to need a different way of thinking, but in the short term, it's preparation, preparation, preparation.
And I think it's really good. I mean, your point that you touched on about having an overlap period, I think would just be invaluable, and something that I really hope that we can see in the near future. But your timing to speak to them in like their junior year, I think is vital, because as they get older into high school, I mean, the transfer of care is only one component of major changes that they're having in their life. I mean, the kids going across the country to different universities, like let alone changing their doctor. Right. You know, there are so many other varying factors that if you leave it too late in the game, it's going to go in one ear and out the other, because they're having life thrown at them in every which direction.
And I think that it's also important to start in their junior and high school for those kids that are going to transition from high school to the workforce, those kids that are going to transition from high school, as you point out, to university. The pattern in Canada is the same as the pattern in the United States. Kids go all over the country to go to university, and they're going to have some knowledge to take with them. So that they can be part of their care team if they run into a medical issue. I think the final point that I would make is we have to recognize as people who care for these children, as families who have these children, as the children themselves, we have to realize that these solutions they're sort of temporary fixes right now. We need some systemic changes so that we handle these kids that have, and they're not going to be a big part of an adult care system, but we have to figure out innovative ways that we can provide the care that's comfortable for them and that is high quality, and that these transitions are seamless. There's another point of transition that we don't talk about. And you may do this much better in Canada than we do it in the United States across the board. And that's the transition from fetal life to postnatal life. Many of these kids are identified in fetal life by maternal fetal medicine docs, et cetera, et cetera. Sometimes pediatric nephrologists are involved in counseling in the prenatal context, but not always. And even if the counseling happens, there's not a clear care plan for the child is born, is in the nursery, maybe is in the NICU, and then they're going to transition into a clinical program that's going to take care of them. And we do that better for other disorders in childhood than we necessarily do for kidney diseases. So that's another place we have to focus.
A lot of work to be done, a lot of progress made, but the journey continues. We'll move on to a couple quicker questions here, appreciating the time. Do you have any recommendations regarding off-label targeted medication for children with ARPKD?
Right, and so I think probably Nasrin is referring to tolvaptan, Ginarc or Ginarq or Cimzia, the tolvaptan drug, and people you know, are knowledgeable that there are common mechanisms, and they say, well, this is a really devastating disease, we should use this drug. And what I would say is I completely understand the rationale. And for that reason, our site is one of the sites that is participating in these new clinical trials in ARPKD. But we need to have the data from those trials to know three things. First, is it safe? Second, is it tolerated? And third, is it efficacious? And just doing something because you can is not necessarily in the best interest of the child. So that would be the major off-label drug that would be a targeted therapy, and we are beginning those clinical trials. Last year, I couldn't say that. This year, I can.
Amazing to hear. Thank you for that. We have a question from Jennifer. Could you elaborate on how the liver component of ARPKD causes spleen inflammation, which affects platelet levels?
So it's actually not spleen inflammation. So remember I talked about the portal vein. That's the vein that's carrying all the nutrients from the intestine, and it has to go into the liver. It goes into the liver into the context of that portal triad with the bile ducts around it, and then also that loose tissue. If the bile ducts don't form normally and the portal vein, branching structure doesn't form normally, it sets up an inflammatory response that can lead to scarring, and the scarring increases the pressure around those veins within the liver. That makes a higher pressure system in the liver than outside the liver. These are veins. There's no pumping in a vein. They're very thin-walled structure. So the blood goes the other direction. One major place that it goes is to the spleen. And for mechanistic reasons we don't completely understand, that causes the spleen not only to enlarge, but to take its sort of appetite for damaged cells and have it go wild. And so it starts gobbling up not just damaged blood cells as it's supposed to do, but gobbling up all kinds of blood cells. And that is called hypersplenism. And that's why the platelet count can go low. And in fact, in severe cases of portal hypertension, that's not the only blood count that can be lower. Also white blood cell counts and even red blood cell counts can be lower. So it is because of that portal hypertension that causes the spleen to become enlarged and even more hungry for cells that are normal cells, not just damaged cells, which is the normal situation.
Great, thank you for that clarification. We get a lot of inquiries from parents surrounding the safety of sports and activities, extracurricular activities, obviously with, kids playing football, karate, jiu-jitsu, all of those kind of hands-on activities. I know that there's safety pads and there's equipment that parents can get depending on the sport. What do you tell your patients and their families that are looking to get involved in active sports? So
let me say overall, I think athletic activities in children are hugely important. They're not just important for establishing a pattern early in life of physical exercise and activity, but for many kids, it's a way to socialize outside the classroom. It's a way for them to have accomplishments that add to their portfolio of things that cause them to feel good about themselves and enhance their self-esteem. So I'm all for sports, organized sports in children. I'm going to answer this thinking about the dominant form of PKD and the recessive form of PKD. You mentioned in your really very kind introduction that I spent a long time at the University of Alabama at Birmingham. So you all know that that there are certain parts of the United States where football is king, and in the Deep South, football, including very competitive football, starts at a very young age. I learned very early that it is not the time to speak to a child about not playing competitive football when they're 12 years old, because by that point, they're either really good and this is something that they want to pursue, or they've already given it up. You really need to start to, if you have the opportunity, to manage their choices of sports. So thinking about, cross country, thinking about, I know that soccer can be a contact sport, as can basketball, but not in the same way as football. And so I tried to sort of steer my patients away from football. But all is not lost if you don't see a patient until very early. So I had a really remarkable experience with a young man, a little anecdote because I think it illustrates, a young man who I started to see when he was, something like 13 years old. He was on the cusp of going to high school. He was not a very talented student, but he was a terrific football player. And he had huge kidneys. I really just could not countenance supporting him continuing to play competitive football, particularly the way it's played in the Deep South. It's a very competitive sport, a very physical sport. And his mother was beside herself because the football field is where this kid got his self-esteem. And in the course of a discussion, something that I now look back on, and I can't believe I had the chutzpah to say this to this kid, but I said to him, you love football so much, who else is on the field? I'm a big sports fan, as you know, Jeff. I know exactly what other kinds of players are on the field. And so he mentioned this, that, and the other thing, and he didn't want to be a trainer, and he didn't want to be this. And he mentioned the cheerleaders in passing. And for some reason, I picked up on that, and I said, oh, cheerleaders, are they all girls at your high school? No, there are boys as well. Cut to the chase. By the time he was a sophomore in high school, he was the captain of the cheerleading squad. He got to be on the field for every game. He was the captain. It did tremendous things for his self-esteem. We went someplace that you wouldn't have thought, but we went there because that would have kept him safe. So I think that there are choices that can be made that can still be affirming for a child. For a kid with ARPKD who has hypersplenism, you don't want them to rupture their spleens. Now, interestingly, I'm speaking to a Canadian audience where hockey is king. And you would say, well, it's a very physical sport. And being, I hate to tell you this, but a Boston Bruins fan, I actually know it's a very competitive and physical sport. And sometimes not always in the cleanest way, but that's beside the point. The thing is that hockey, though, you are very, very well padded. And so I think making choices that take the total child into consideration. And if playing hockey or playing some of these sports is really important, to think about ways you can protect them. It's not a blanket yes or no, this is right, this is wrong kind of answer. But you have to take into consideration that there is a risk. Of course, there is a risk from absenting them from things that they really want to do. And so you have to have conversations. The bottom line in ADPKD with football, in ARPKD with contact sports, is the family has to sit together, parents and the child with the healthcare providers, and think about, in this situation, what are the various risks? What's our risk tolerance? And to come up with a plan. Because unfortunately, there isn't a script that is the right answer.
Oh, absolutely, and every patient is so different. You really have to look at the overall picture for sure. We have time for a couple more questions, Dr. Guay Woodford.
And Jeff, if I could just tell you, if it's obviously 9 o'clock here in the East Coast, I don't have anything else tonight. So if people want to ask questions for a while, I'm very happy. But if you have something else for your programming, that I understand.
I'm all yours, and this is it for tonight. So we'll run through the questions and give them space. Thank you for that offer. Parents obviously have reservations about traveling with their kids, and of course, there's a wide spectrum of one's condition. How do you provide insight into parents into making that informed decision about traveling out of the country, especially with the way insurance policies work and the costs of something happening in the States versus happening here in Canada? What guidance do you provide them to, again, live their life, but also recognize the risk-reward ratio?
Right. So I must say, as you well know, we have a very heterogeneous healthcare system in the US. There are people who have terrific insurance that allows them all kinds of flexibility in terms of their physical location, and other people who are very restricted. And so again, it's a conversation. If you have a child with ADPKD who has well-controlled high blood pressure, normal renal function, does not have some of the other sorts of morbidities, recurrent pain issues with recurrent stones, et cetera, I think that that's a relatively low risk situation for travel. If you have a child with ARPKD who's on 3 medications and barely controlling their blood pressure, who's having difficulty eating, and we're really struggling with weight gain and linear growth, short trips might be okay. Longer trips might complicate things. And so again, I think there really isn't a single answer. And then, of course, everything gets complicated by COVID. Until we had vaccinations that went down to 6 months of age, then people had to think about, well, coming to the United States where there's incredible variability in terms of people wearing masks and this, that, and the other thing. Going to Disney World, you might take your life in your hands in Florida. I get it. These are conversations that I think that first families have to have, and then consulting with your physician about your child's specific situation, because there's a scale of severity, right? And kids who are on the milder end of things, not just for them, but for the family and for their sibship, you don't want to just automatically have them be the drag on the family's social activities, including travel. On the other end of the spectrum, you want to figure out how can you prepare sibships for, we have to take these special considerations into account in thinking about where we're planning our vacation, or even if we're going.
Excellent insight. Thank you for that. With respect to the clinical trials and gaining added insight from those studies, we have a couple people asking tonight and emailed early about getting involved. So participating in those studies, are there still opportunities for families to jump in?
So let's take the two disorders.
Sure.
So the first in ADPKD. So there was a study that's just been completed in Europe, a randomized controlled study, small, relatively small, only about 90, 100 patients. And it really looked at tolvaptan to ask the question, 3 questions. Is it physiologically active in children? A group of children. The answer was yes. Could it slow the rate of kidney growth? Because remember, kidney growth in ADPKD tends to go like that. Small cohort, so not really a well-powered study, but there is the sort of the indication that it could slow growth, so it might be efficacious. And another very important issue is this drug causes you to pee like a bandit. Adults can pee 7 liters of urine a day. And so what does that mean about children? And the job of a child is to go to school. Going to school, being able to learn, being able to concentrate, being able to socialize. And that seemed to be tolerable in this study. That was a European study where there is discussion about opening that same kind of study up in the United States and in Canada. The study that I referred to, the 2 studies that I referred to, one in the very young group of children to sort of 1 month to 3 months, that's open in the United States, but to a very limited number of sites. So only 10 sites and it's just in terms of North America in the United States. So our center, Cincinnati, Cleveland, Emory, the Mayo Clinic. So it's 10 sites worldwide, I think the 5 in the United States. And we actually are enrolling patients from around the country. But you have to understand that there is a challenge to doing this. You have to come for a baseline visit. You have to come for the screening visit. And then you have to come once a month for 6 months. And that's a lot of burden on families. But it is possible. So we have a patient that we've enrolled now from Alabama, and we have a patient locally that is part of this study. The study for the full range of childhood has more sites around the world and 10 US sites. But it's the same sort of thing, baseline screening, and then once a month for 6 months. So I would say to you, I use that to sort of illustrate the point that clinical trials, you have to think about very carefully about not just the trial itself, and does your child want to be part of it, with the imaging, with the repetitive blood drawing, with the disruption in terms of travel. Now, one of the good things about these particular clinical trials is after 6 months, if you live, for example, far away from DC, that we will send a visiting nurse to do the follow-up visits. But still, there is some disruption there. I think that you can trust in both the United States and Canada that to the best of our knowledge, we have de-risked these studies as much as possible. Studying an unknown question, will this drug be safe? Is it tolerable? Will it be efficacious? But we've tried to put all sorts of safety checks in place so that we minimize the risk of harm, but it's not completely absent. Another thing families have to understand about therapeutic trials is that truly participating in a clinical trial is altruism, because there is no guarantee that any benefit will accrue to your child. So you can't sort of get involved in a clinical trial and say, well, my child will get better care. In adult studies, actually the standard of care does improve a bit, but I'm not sure it's as much in children, because particularly for kids with rare diseases, we have a mechanism that does a really good job caring for these children. So involving your child in a clinical trial is really an act of altruism. And that act of altruism has to, at least in the United States, be discussed with the child, for example, when they're 12 or older, because they have to assent to doing it. Now, there are other ways to get involved in research, and I appreciate your direct and bold plug for being involved in a registry. A registry costs you nothing. And there's very, very limited risk, because the risk primarily is that the confidentiality, the anonymity of your child participating in that registry might somehow be violated by a data breach. And we put all kinds of mechanisms in place for that not to be an issue. And so certainly we would welcome participation from our Canadian colleagues and patients in Canada in our registry. So there are registries, there are therapeutic trials. There are also increasingly studies that are looking at quality of life issues. And so, for example, we are conducting with a colleague in Germany a patient-reported outcome study looking at what are the priorities of families for children with ARPKD, and that we can conduct. Registries, you send your records. This is a study where we have to interact with you. But COVID, the silver lining in COVID is we're all really good with this medium. So our study, even for our local patients, is now entire, so that we have the same approach. It's entirely done by Zoom. And so if people are interested, we would welcome patients from Canada being involved.
Well, let's stay connected on that. I'd love to obviously throw the foundation support behind that, and I know our members and families here in Canada would love to get involved in any capacity for sure. So I think that's a to be continued. Time for one last question, Dr. Guay Woodford. Families' reservations about getting their children tested, and at what age to possibly get that when there's the family known history. The biggest issue is obviously health insurance and getting coverage, the premiums, inflations surrounding that. I know the US is different in all shapes and sizes when it comes to this than here in Canada, but how do you speak to families that have those reservations?
So, I probably would break my answer down into 3 parts.
Okay.
The first is does the child manifest any sort of signs or symptom of the disease? So blood in the urine, protein in the urine, pain, high blood pressure. Then those are the promontory signs that the child's issues that you're seeing may be due to cystic kidney disease. And then I think it really is, it is in the best interest of the child to evaluate them. It's not screening. So I'm going to use 2 different words here. That's evaluating a child whose clinical presentation is prompting you to say, this is a child at risk for ADPKD. I think that I'm going to go ahead and, I think it's appropriate to go ahead because they have hypertension or blood in the urine or protein in the urine to screen them, because I think that's going to be the answer to what's going on. Then there is the child with ADPKD that's entirely asymptomatic. And, I mentioned that wonderful consensus report from 2019. And let me just, I have it here. I can put, so let me just share with you as I'm talking about this. Yeah. So I'll put this in the chat. Oh, well, I'll see if I can put this in the chat. So this report dealt with that issue. And essentially what it says is that there is no right or wrong answer. That children who are at risk should be screened for hypertension, blood in the urine, protein in the urine, et cetera, because then with that screening, they should be evaluated if anything becomes positive. Then it does boil down to a conversation again, because it's what devil can the family live with? And I would caution families that doing an imaging study, which most likely will be an ultrasound, in a school-age child can give you temporary relief that, oh, we see normal kidneys. But ADPKD is a slowly progressive disorder, and there is in younger children a risk of false negatives. So you can't say, oh, my child at 6 years of age had an ultrasound, no cysts, we're home free. Okay. There is the issue of using genetics. We do not typically use genetics in our diagnostic armamentarium for kids with ADPKD in the United States, except if there's no family history. There are unusual circumstances, no family history, et cetera, or there's very atypical findings in an adult or in the child that we really want to sort it out. But genetics, I think, increasingly will be very helpful. Then you have to think about, you're taking an asymptomatic child and you're making, you're doing a study that will confirm that this child is carrying a disease gene and ergo is destined to develop disease. Is that knowledge something, number one, you can act on now? And I would argue that in 2022, for a completely asymptomatic child, knowing whether or not they've inherited the disease gene in ADPKD, we would do nothing different. We don't have any, preemptive strategy that's going to really, really slow the course of the disease that they will develop. And that's important because to me, it's an ethical consideration. The other thing is we have to think about the autonomy of the child. Does that child want to know? And you can't ask a child, right? But the point is that you have to think about those sorts of issues. Okay? Now, I have just had a family who has their oldest child has ARPKD, fortunately not a very severe course, and has now in rapid succession 3 very young siblings. ARPKD tends to be a more severe disease and tends to have morbidity younger in life. And so rather than lining up this 1-year-old, 2-year-old, and 3-year-old for a series of ultrasounds, what I think would be more appropriate, we know the genetic defect in that oldest child, is to just do genetic testing on these younger children. And what the family and I came to was that when they got to be 3, so that a blood draw was easier or a buccal swab was easier, that we would do the testing. So we've done the first child, and fortunately that child did not inherit 2 copies of the disease. I think in that situation, it's a little different than ADPKD because the burden of disease can be substantial and can happen at a very young age. Does that make sense, Jeff?
A lot of sense, and I'm always amazed at how you can just put it out there in a way that a guy like me can understand. Thank you so much, Dr. Guay Woodford. It's been an absolute pleasure. So much information shared and so much hope given to those with children with ADPKD and ARPKD. So, on behalf of myself and the foundation, just thank you so much for everything that you have done over the years and continue to do. It's absolutely amazing.
Well, thank you for inviting me to participate. Good night.
Absolutely. We'll be in touch. Bye-bye. Okay, everyone, that concludes this evening's night 1 of the PKD Summit 2022. Thank you so much for joining us this evening. There's still time, of course, to register for tomorrow night, night 2 of the summit, as well as next Wednesday and Thursday's events. So I encourage, if you haven't signed up for those but are interested, We have a wide range of topics. We look forward to welcoming you. You can visit the www.pkdsummit.ca and sign up for those remaining summits. We'd love to have you join us. And as Marie just shared in the webinar chat, there is a SurveyMonkey link. If you're still with us and are able to fill that out, we'd greatly appreciate any feedback you can provide from this evening's events. So thank you again for joining us this evening. I hope you found it as insightful and informative as I did, and we look forward to welcoming you at our next event tomorrow evening at 6:30. Have a great night. Bye-bye.